It's an honor and a privilege for me to introduce Dr. Paul Long. I've known for a number of years. Paul graduated with a BA degree at Queens College in New York. He then had the adventurous insight to go to Belgium, where he went to the University of Brussels, in Brussels, Belgium, and received his medical degree. He continued as in the area of medicine and research by becoming a neurology resident at SUNY at Stony Brook in New York and the VA Medical Center there. And he's had a long history of working with patients to evaluate and treat for neurological problems, peripheral neuropathies, chronic pain, and especially traumatic brain injury. He's unique in being able to bring together a multimodal perspective from nerve conduction velocities and muscle measurements to EEG, QEEG, evoked potentials, SPEC, and MRI. And it's going to be a good and interesting talk that Paul is going to present today with special emphasis on traumatic brain injury and his unique multimodal approach to evaluating and treating traumatic brain injury, and also with his new book that he'll be able to discuss, and it integrates all these special things called the Concussion Cure. And so I want to give everybody, should give him a hand to come up and give his talk. Thank you, Paul.
Thank you, Bob. Thank everybody for coming. I also want to thank ISNR for accepting my proposal to be a keynote speaker. Also want to especially thank Professor Lubar for encouraging me to make that application. And so we're going to change things up a little bit now compared to the previous presentations, and we're going to talk about some very, very practical things and teach you, and I promise that I'll teach you and you'll understand what really needs to be done to properly diagnose and treat a concussion. Most of the information that I'm going to relate today is contained in my book, which you see there, The Concussion Cure. Some of it has more details than others, but some of the information that I'm going to relate today is going to be more detailed because this is a professional audience, and that version of the book was specifically designed for the lay audience. Although it has so much information about SPEC scans, which I think most of the people here in the audience don't know that much about, so you could also learn quite a bit. So what is the problem with regarding traumatic brain injury? And the problem is that there is, in fact, no standard treatment. And the reason I say that is because there are different practitioners out there, you foremost for neurofeedback, that do things to help improve the condition. But the three separate communities that address and treat these patients work in isolation, so that you, the neurofeedback community, which I respect tremendously and work with, of course, you do a lot of good with the neurofeedback, but sometimes that's not enough. The people that do hyperbaric oxygen do great work, and I'll talk about some more in detail, but they don't have anything to do with anybody else. So the MDs are sort of isolated, and they don't understand that putting all the different possible modalities of treatment together can make a difference. And that's why I put together several different modalities, which I have called the WAN protocol. Oops. So the solution is, as you know, to do neurofeedback, supplements if the patients are interested in, and then my protocol, which I'll talk about in greater detail. If all those three modalities are put together at the same time and used to treat the patient simultaneously, there is a synergistic effect. Now, you may be wondering, how did I come across this? And there's kind of a long story to this, which I'll summarize. Starting in 1990, I was introduced to the technology of SPEC scan. And I'll get into that in greater detail in a moment. but I immediately realized that it was a very useful test for traumatic brain injury because it showed the same pattern in virtually all the patients, a decrease of blood flow and a characteristic pattern which I'll show you. At around the same time, I postulated if the problem is a decrease of blood flow, why wouldn't the treatment be an increase of blood flow? Simple and elegant. And I knew that there was a medication FDA approved for subarachnoid hemorrhage, which causes spasming in the brain and decreased blood flow, which is exactly what I saw in the SPECT scan. And I said, why wouldn't these patients get better with this medication? So I started to prescribe it off-label, and one after another, and guess what? They all got better. At around the same time, I discovered hyperbaric oxygen. And that works actually differently than the medication, so the combination of the two are in fact synergistic. In and around 2007, I was introduced to neurofeedback by one of your colleagues, Dr. Gerald Gluck. And here's a picture of my good friend who just passed away about a week ago, sudden heart attack. I got the call at 2:30 in the morning, and they couldn't revive him, and he was pronounced DOA at the hospital. And he will be sorely missed. And this was announced on the listserv, so probably many of you know that. Back to the story of how this protocol developed. So Jerry and I started working closely together. In fact, we shared the same office and started referring patients back and forth. And what we noticed was that the trauma patients that took the medication in combination with neurofeedback actually got better faster and had even a more complete recovery. And the rationale behind that is that when you perform neurofeedback, there's an automatic demand for increased blood flow. But when you have decreased blood flow seen on the SPECT scan, you may not be able to meet that demand. When you take the medication and you increase your blood flow, it helps the brain meet that demand, makes the neurofeedback go better. So now I want to get into a little bit more detail about how I think concussions should be identified, diagnosed if you're a physician, and treated. First thing that most people in this room would do is you would take an intake. Doctors call that a history, and it should be very detailed. Second thing is go through the proper steps of treatment, which I'll describe in greater detail as we go along. It's also important to know when the patient reaches maximum medical improvement, meaning when do you stop using neurofeedback? And for those practitioners that don't do Loretta Z-score neurofeedback, they really don't know when. And they can overtreat and they can hurt somebody. So that's very important. And I understand that and I recognize that. Another secondary effect of all this is that when you help people more, you develop more referrals and you actually make more money for yourself. Not a bad thing, right? So I'm going to tell you about several case histories now to demonstrate to you that the treatment really does work and why the book is called Concussion Cure. And so the first case is from 1995 or 6, and my patient was a policeman like you see in the slide, and he was actually outside the car when another vehicle struck him, caused him to catapult up into the air, and he went into the through the windshield head first, breaking multiple bones in the face and the collarbone, sustaining a hematoma on the left side of the brain, immediate coma, went to the hospital, was in very bad shape. It was a work-related case, and I was somehow able to get permission to videotape his neurological status. While this videotape was never meant to be used for a keynote speech, I've adapted it so it's not the best, but it's certainly visible. You can see what's happening. So first I'm going to show you the pre-treatment neurological examination. Let's see. Okay, Joey, can you look at my finger and follow the one finger? Follow my finger with your eyes. Don't move your head. Okay. Look all the way to the right. Look here, Joey. How many fingers? 3. Okay. Look over there. Look to your left. Palms the other way. Palms facing the ceiling. Joey, palms up. Your fingers up and down. As fast. That's it. As fast as you can. This would be the equivalent. Or down. Joey. Okay, yeah. Can you tell me if this object is warm or cold? Warm? Cold. You're going to close your eyes and tell me if you can feel it and guess the number, okay? Okay. Okay, close your eyes. What number? That's cold. What's that? Somebody that wants to make eggs wrong. All right, give me a number, Joey. What number? 95. 95? 95, but it's a single-digit number. One number. Okay? Ready? Here we go. Ready? What number? Okay. Stopping the video because this is where the post-treatment starts here. So the observations are that the patient is very lethargic, has major weakness on the right side of the body, which corresponded to the left hematoma in the brain, and extremely slurred speech, like a very inebriated person, to the point where it's very difficult to understand him. So the treatment that he underwent was the same cognitive rehabilitation and physical therapy that he had been going to all along. And then I gave him the medication, which I'll tell you about in more detail soon. And he was ordered to have 90 hyperbaric oxygen treatments, but he did so well that I decided to interrupt it at treatment number 62, and we re-videotaped him. Now this is the post-treatment video. How you feeling?
Not too good.
In what regard?
I had broken legs. Broken legs hurt.
Both feet. Be careful like now. Look at my finger.
Finger.
Okay, hold your head still. In the middle. Look at my finger. Follow my finger with your eyes. Don't move your head. All the way over. Good. All the way over. The camera over there. So as you teach as much as you can, we can see that there's still a little asymmetry. This one is higher and more indented. And he still has his pronator drift, but his whole arm is not falling down. It's just drifting into the pronator position, so that's good. Okay, like this, okay? Now pull those fingers back, pull them back, and I can barely push them down, okay? Now pull these fingers back. Ready? Pull back. And that's holding up pretty good. 2 fingers, tap, 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 as fast as you can. And this is rapid alternating movement or finger tapping, finger oscillation test, and he can actually tap the fingers, which he couldn't do last time. Good, I can't, he doesn't have a foot drop there anymore. You pull that one up?
That was broken.
Okay, pull up, pull up.
Like a
And that one
man.
still goes down, okay. Now, push down, step down. Okay, okay. He's got some power pushing down, but there's still some, okay, you can relax your leg. Can everybody see the difference? Obviously much more alert, speech much less splurred, mild weakness on the right side, practically no weakness on the left side, and cognitively more intact. Those videos were greatly edited, and there's more to the examination that would show more, but time doesn't permit. So that was the first case, and later in the presentation, when I show you SPECT scans, I'm going to show you his SPECT scan pre-treatment and post-treatment, and it's pretty obvious and dramatic what the differences are. So, having said that, I have a question for the audience, which is, what does a fireman and emphysema or COPD patients have in common? Anybody want to venture an answer? No hands? No guesses? Correct. So that's why the title of my next slide is Oxygen is King. And we all know that oxygen is vital for life, at least aerobic forms. It's attached to hemoglobin in the blood, so it is therefore linked to blood flow. Blood flow is linked to the diameter of the artery or arteriole, and these may be increased or decreased depending upon what is happening in the body and the brain. And that's sort of like a background basis to understand more about how the treatment works. So the next patient is also in the category of severe TBI. The next two will be mild, but I happen to have another severe TBI that I was able to record the pre and post neurological examination as well. And this was recorded on a regular cell phone. So once again, it's not the best quality, but it does work. This patient was injured about 9 years ago, crushed by a large, rapid-moving truck that crashed right into her. They had to use the jaws of life for 45 minutes to cut her out. They thought she was dead. Somebody heard a faint heartbeat. They revived her. They took her to the hospital in deep coma. She remained in deep coma for many, many months. When she woke up, she was very, very lethargic, worse than the other patient, and she took many, many, many months to wake up, unlike what you see on TV.
Recording it.
Okay. So Jody, I'm going to scratch the bottom of your left foot like we did before. Don't pull back, all right? Okay, and she pulls back just a little bit, but you can see that the toes go down immediately. Okay, relax your left leg. Okay, now concentrate on your right foot. We notice that the foot is a little bit red. This is a dependent rubor, which is related to the innervation of the skin. And she holds her right great toe in extension, which is also known as a tonic Babinski sign, but she does have some voluntary control over it. She is able to relax it. Jody, yes, keep relaxing your right foot, your big toe, and I'm going to scratch the bottom like I did before, and please try not to pull back. Okay, no, relax your toe. Relax the toe, let it go down. Let your big toe go down. Big toe has to go down. Let it, okay, right like that. No, let it stay down. Good, let it stay down. Now I'm gonna, no. Give me 2 seconds, all right, Jody? 2 seconds. Toe down, down. No, the other way, down. And now we see when I scratch the bottom of the foot, which is called the Babinski, the plantar reflex rather, the toe immediately goes up, which is a positive Babinski sign. Okay, all right. Jody, you want to say something for the video audience? You want to try to say something for us? Huh? A little louder so we can hear. You want to come closer with the camera? Maybe we can catch it. So you say hello. Okay. How you doing?
How are you?
How are you?
Yeah.
Okay. All right.
Okay, stop.
Okay, that'll do. Okay, so a few comments about her baseline status. Severely impaired, similar to the other patient. You'll notice that her head is tilted to the left in a very peculiar manner. And the reason for that is because part of her neurological deficit is that she had a field loss on the left side. For the neurologist, if any are present, it was homogeneous hemianopsia. And when she turned her head to the left, it allowed the right side of the visual field to come into play, which enabled her to see. And this is important because it's a major focal deficit, and also it got better with the treatment. You'll notice that the left arm is moving a lot, the right arm is spastic and flexed like this, the right leg is out straight, the left leg is somewhat bent. So the treatment was a rapid course of treatment because she was visiting from Canada. So she had about only a 5 or 6 week window of treatment, during which time I saw her once a week. I rapidly escalated the dose of the medication. She went to neurofeedback twice a day with Dr. Gluck, and she had hyperbaric oxygen once a day, 5 days a week. And this is what she looked like between the 5th and 6th week. And notice the head is up straight. Right. This is the neurological examination on Jody visiting from Canada, and she's taking nimodipine, and she did start to go back to neurofeedback.
She's wearing a mouth guard in her
For
getting her jaw and her teeth back in. She's gone from just 2 teeth that her 2 jaws met, and now she's got.
Okay, stick out your tongue. Okay, midline. Okay, good. You feel this? Does that feel the same? Yeah? Okay, good. Okay.
That was the first time that was midlining.
It was? Mm-hmm. So the arm is
I got
very
gooses.
tight, which is spastic, and this arm is not spastic. Okay, let's see. And so hold your fingers up, straight up, up. Keep your fingers up. Straight up. Don't let me push you down. Keep them up, straight up. Hold one place. Up. Pretty good. Do these fingers go up, Ron? Very tight. Fisting. Grasp reflex, very tight. They don't go up, do they?
Well, yeah.
Feel cold. Very cold. So she
Queen
doesn't really
square
have
hammer.
hyperactive reflexes because she's so tight on the spasticity. And this side, you know, let it go. This side might be more able to move. Okay. Relax your legs. Let's see, watch this leg. So that's okay, because it's brisk, but it doesn't go across. Let's see if this one. That one doesn't go across either. Okay. So let's see what's doing at the ankles here. We'll do the better leg first. Bit of an ankle jerk. And this foot, of course, doesn't really move much because it's very spastic. I don't expect the ankle jerk to go anywhere because it's too tight. And let's see and the big toe did go down, so that's completely normal. Can you feel if the instrument is cold or cool? Is it cold or cool? The left is, the right is not. All right, can you feel the vibration on your wrist right there? And how does it compare to that? Does it feel the same? Yeah? Okay. Okay, so clearly an improvement, and the head is straight because the vision was improved by about 25%. She only had about a 25% loss of field. I'm not going to go into all the other details because I think I'm running a little bit behind on time, so in the effort to get done. So, the question is, does this treatment really work? And those were examples of severe cases, and now we're going to start some cases of what's called MTBI. So this is a young fellow, 22 years old, who had multiple sports concussions, and his problem was that he was having academic difficulty in school, going from A's to B's to failing. He saw Dr. Gluck first, had an abnormal QEG. He saw me, and I did the SPECT scan, and it was severely abnormal, so that's why I think the name of MTBI is a misnomer. I'll show you that later. He was treated with the same protocol, medication or feedback. Later on, he added hyperbaric. He had serial SPECT scans. I'm going to show you some of them. And you can actually see that the areas of decreased blood flow get smaller and less significant statistically. Gradually, he improved. The next case is actually his brother, 1 year younger. His case was a little bit different because he had depression with suicidal ideation, the same academic deterioration, and he had a specific history of 2 sports injuries, and one of them, at the age of 14, he was hit in the head by the soccer ball playing goalie. He actually went down. He was counted out for about 1 minute, so unconscious. Curiously, he got up and he was asymptomatic, so nobody thought that he had a problem, and he never went to the hospital. So his course was very similar. The QEG showed the classic trauma pattern of short-paired hypocoherence and long-paired hypercoherence. The SPECT scan showed a classical trauma pattern, what we call coup contra coup, had the same treatment and basically the same results, improvement gradually, slowly over time. So what is the modern definition of a concussion? There's a big difference with the old one. So the modern definition says that it's only a temporary interruption of ongoing cerebral activity, and it may happen from a direct hit or an indirect hit. An example of an indirect hit is a whiplash in a car. And the mechanism of injury is the acceleration, deceleration with torsional effects, and there may or may not be a loss of consciousness. It really doesn't matter as far as getting a diagnosis of concussion. It's only a question of a degree. Some of the patients have amnesia, some don't. And as I mentioned, this is quite different than the previous definition. So how do we grade concussions? And this comes from the neurology literature and emphasis on sports. And so the mildest grade 1 is no LOC, loss of consciousness. A grade 2 is a brief loss, less than 30 minutes. And a grade 3 is greater than 30 minutes, which usually means the patient is in a coma. So that's how we identify that. Now, what are the other methods that we use to identify, and how do we make the diagnosis? First is the history or the initial intake, neurological examination, which I'm going to skip over for the sake of time. But I will tell you that if the neurological examination is done in detail, there are specific findings. It is a very sensitive test. The problem is that most neurologists omit them. For example, they'll do gross motor testing. They won't do fine motor testing. And the problem is with the fine motor, just like cortical modalities, secondary cortical modalities. Diagnostic testing divided between functional and structural. I'll start with structural to say that they're not very useful because 80 to 90% of the time, even an MRI is normal. A normal scan doesn't help. Someone goes to the hospital, they typically get a CT scan, and they said, well, your scan is negative, you'll be fine. And that's true, they say, in about 80% of the cases. I think the number is inflated compared to what I see. Nevertheless, it means that 20% of 5 million cases per year means 1 million cases of TBI per year don't get better. That's why I call it an epidemic. So the functional tests are the QEEG and the SPECT scan, and I'm not going to spend a lot of time on the QEEG because just about everybody here does that, so that's why we're going to spend more time on the SPECT. But I will say that as far as localization goes, and everybody has heard Dr. Thatcher say localization, localization, localizations, and I will reiterate that there is a tremendously positive correlation of the focal findings between the SPECT scan done properly and the QEEG, and this was published, Jerry Gluck and I published this in 2014 in the excellent book that probably many of you have, which is the Z-score Loretta Neurofeedback. So now let's sort of get into the meat of the presentation and talk about a SPECT scan. So first of all, this is in the category of a nuclear medicine test. And it's just like a bone scan or a stress test for the heart, and it's specifically designed for the brain. We use a specific radionucleotide, which is better for the brain, and it does require an IV injection. It is not dangerous. It contains less energy than a PET scan, which is useless, practically useless for TBI, because the PET scan measures glucose, and we want to know what oxygen levels are, which is reflected by blood flow. That's why I don't do PET scans. So in order to understand the SPECT scans, PET is the same planes, you have to understand the various planes. Some of you, if you've seen MRI, those planes are the same. And we have the red sagittal, which is slices from left to right. The blue teal color is coronal, which goes from front to back. And the green color is horizontal or transverse, which goes from the bottom to the top. And you need to be mindful of that when we start looking at examples of SPECT scans as we go along. Now, I'd be remiss if I didn't have at least one slide with a little humor. And so this is the poor football player that's losing his brain from concussions. And this is the NFL people that losing their heart because they're heartless, but they're carrying their money all the way to the bank. All right, back to serious work. So what does the brain look like when you have a concussion under the microscope? So the comparison here is normal on the left, TBI in the middle, and boxer on the right. And what we're looking at on the brown color stain is tau. And tau is an abnormal protein that's deposited in the brain. And the pattern, however, is very, very specific. It is different between the distribution in TBI and in Alzheimer's, where many of the studies have been done. So now we're going to start to look at some of the SPECT scans in post-concussion syndrome. So the technology has evolved a lot over the years. It used to be, up until a few years ago, that the best scanner was called the triple head. That means 3 cameras. And the resolution is the best with the triple head, between 2 and 2.5 millimeters. The slices that can be put through the brain are down to about 2.2 millimeters, but they can be stacked. We have all the usual views of MRI, but in addition, in SPECT, we have some very unique views that no other technology of imaging allows us to see, and I will show you them as we go along. The place that I send my patients to has a normative database. It does not have a large N, but it does seem to work. So all SPECT scans should be done with a flow study, and what you see here is the carotid distribution before it gets to the brain. And the reason to look at that is because if you have an older person, let's say, for example, that has a carotid artery stenosis, this can affect and decrease the blood flow in the brain. So you don't want to say, if you see hypoperfusion, decreased blood flow in the brain, and then, let's say in the left hemisphere, wherever it might be, you don't want to blame it all on a TBI if there's a carotid artery stenosis below. So that's used to rule that out. The next is an example of a TBI patient, and these are the axial cuts. Remember, those are the ones that go from bottom to the top. I will call your attention to the color scale on the right, which shows you that the hot colors, white and red, are the normal, and the dark colors are the abnormal because it represents a low flow state. The slice where the arrow is may be difficult for you to see, but there is nevertheless an area of blue adjacent to light yellow, and the other side shows greater yellow, and that's the left inferior frontal lobe, and I promise you'll see that a lot better on subsequent slides. This is the coronal view, which is great to look at the temporal lobes because this is slicing from front to back, and you can see line 1 where the arrow is, that the bottom of the left frontal lobe, it's like, hello, it's not there, it's absent. And that corresponds to what we saw on the other one. So in SPECT interpretation, we say you have to see the same thing at least on 2 views, better if you see it on 3. The second line, which shows the other red arrow, shows the left temporal lobe. And if you scan across the second row, you can kind of see the temporal lobe fills out like a donut, but over there you see that the lateral aspect and the inferior aspect of the temporal lobe is quite blue, so low on the flow scale if you look to the right. Now, if you want to look at that a little better, I have the ability to do blow-ups, and this was published in Z-score Loretta neurofeedback. And what you see is an example of excellent neuroanatomical correlation of localization. And the SPECT imaging on the right, I should say, has the opposite orientation of QEEG, and that's something to do with traditional radiology and looking up and looking down. But the SPECT image on the left-hand side of your picture shows the red arrow pointing to the right medial lobe as an area of focal hypoperfusion. And the Loretta image on the right is pointing to the same area, Brodmann area 27, at about 2.39 deviation. So very positive correlation. The next images is the sagittal view, and these are slices from left to right. And the second line, last image to the right, the arrow is pointing to large areas of prefrontal and frontal cortex where it's blue, so it's underperfused. The line below that has an arrow pointing towards a V-shaped deficit, which is seen on other cuts too. And we say that that V-shaped deficit is classical of a vascular etiology. Next is an example of 3D QEEG and 3D SPECT scan of the raw data. So what you see is the QEEG to the left shows 1 hertz delta on the left, prefrontal. And if you look at the scan to the right, the arrow is pointing to the prefrontal cortex. And you can see blue everywhere, but if you look at the very edge, it's even less blue. So again, very good correlation. This is the posterior view. So now when you look at the SPECT scan on the right, right is right and left is left, and we have the same positive correlation. If you analyze the distribution of these maximum focal abnormalities, i.e. the left frontal and the right posterior, which we just saw on both the 2D and the 3D. And if you draw a line between those two areas, you can actually create a vector of force. It's actually quite accurate with the history because this person's injury was that the ceiling in his living room fell down on his head on the left side. He sustained this injury. We have prettier pictures also. These are models of the brain upon which the patient's perfusion is superimposed. It just enables us to see the deficits better, but it also enables us to see some of the things that I mentioned that you couldn't see before. So for example, let's see if I can use the pointer here. Can everybody see this pointer moving? Yes or no? No? Okay, well, on the bottom row, on the image to the right, is the bottom of the brain called the ventral surface. You will notice that there is no brainstem and no cerebellum. They were digitally subtracted. So what we're looking at for the first time ever in life is the ventral surface of the medial and inferior temporal and occipital lobes. Because right behind the temporal lobe is the occipital lobe, especially inferiorly. Superiorly, it's the parietal lobe. What you see there are large areas of green deficits. And if you go a little bit up in the picture, you see the bottom of the frontal lobes, and you see these large areas of blue. And if you look at the color scale, you see that blue is close to the bottom. So that's a low flow state. The arrows point to deficits that were seen on the other views, confirmed on this view. I will point out the next to the last image to the right, the bottom row, if you're counting 1, 2, 3, third image from the left. So there's an area, a focal area of decreased blood flow denoted by the red arrow, Broadband area 17, primary visual cortex. And right next to it, there's an area of what appears to be increased blood flow. That's visual associative cortex, maybe 18 or 19. And one could ask, what's the significance of that? And we're going to find out in 2 slides later. So SPEC has some other fancy modalities of showing defects. This is a filter that's applied, and it allows that left inferior frontal lobe defect to be seen more carefully, and it matches what you see on the QEEG to the right of it. So the last slide of this case presentation is a statistical analysis, and I told you that they had a normative database. And what you see in the bottom row, image number 1, 2, 3, is that there's the colors appear to be dark, like dark blue and teal colored. And we look to the right, the color scale corresponds to -2, -3, -4 deviations. And so all that area is statistically significantly deviant because there's a decrease of blood flow. And the area of question of possible hyperperfusion adjacent to that, laterally to the right, actually is hyperperfused. And if you look at the top of that flow scale, you see it's in red color, which is +2 deviations. The left frontal area is depicted by the slide right above that with the red arrow, and there's an area of about -4 deviations surrounded by -3 and then 2 deviations. So the last comment about this section, and this is the end of the case histories, is that I thought it would be a good idea to include in a book a sample prescription of how to order the SPEC scan. So essentially what patients can do, or what doctors and practitioners can do, this can be reproduced on any physician's prescription, and you can go to your doctor and say, this is what I would like to get done, because it has all the ingredients that you need in it. One more slide just to drive home this notion of vasospasm, which results in hypoperfusion. This is a case of subarachnoid hemorrhage, which is the primary indication for the medication that I use. And the top row shows the left lateral SPEC scan 6 days after the event, and then 10 days. And those black holes that you see are decrease of perfusion or hypoperfusion defects, and clearly much worse on the bottom than the right. And because what happens is as the blood seeps through the brain, it's very irritative and it causes a progressive spasming. Before we had this medication, which I'll tell you about very soon, it was extremely difficult to treat that. And these patients would come in, they would be in very bad shape neurologically, many of them would be in a coma, and many of them would have a stroke after that, just because of the decreased blood flow. Okay, so what are the 3 proven methods? The medication is called nimodipine. As I already told you, it's FDA approved for subarachnoid hemorrhage. It is a calcium channel blocker, specific for the brain, practically doesn't even work on the periphery, which is important when it comes to side effects. It's specific for the brain because it's very liposoluble. That's to get through the blood-brain barrier. It has a dual mechanism of action. It prevents the influx of calcium by blocking the channel, and this prevents the cascade of metabolic events that happen immediately after the injury, ending in cell death, also known as apoptosis. The other mechanism of action is that it dilates the arteries and the arterioles, which is the main blood supply throughout the cortex. This decreases the blood flow, which increases oxygen, and as we already heard, oxygen is king. It's a very safe medication. It's tolerated very well. As I already mentioned, few side effects. It's available in capsule form, more recently in liquid form. I've used it alone in many cases where the patients could not get neurofeedback, could not get hyperbaric. It absolutely works. It helps all symptoms to get better. The drug is relatively expensive in the United States, and for the patients that don't have insurance, I refer them to a certain Canadian online pharmacy where it's affordable. As far as objections to the medication, I've only seen side effects such as peripheral edema on high dose. And patients don't get the high dose until I titrate them up over many months. On rare occasion, I saw one person who had a stroke that I gave it for that actually reversed some of his symptoms. On a low dose, he got some of the edema. But that was it. Okay, so just to review the 3 proven methods, we have the medication, we have neurofeedback, we have hyperbaric oxygen, and I have a very pretty slide to show you so you right hemispheric people will remember this picture about how the medication works. So this is a pretty artistic demonstration of the calcium channel, which is the 2 pillars. And the orange sphere is the medication nimodipine. As you can see, it physically blocks the channel. And the blue spheres is the calcium that's trying to get in. So blocking it is a good thing and a big deal. Could not finish this slide without another little dig at the NFL. And this is a pretty self-explanatory slide where the NFL thinks that the concussions did not cause brain damage, but lately they've admitted that there are some cracks in their theory and cracks in the brain and helmets as well. All right, back to some serious information about nimodipine. So I did a literature search several times, and in as many places as I could, and I could not find any literature on nimodipine for mild traumatic brain injury. Yes, plenty of articles for severe, actually not very favorable, except for one that had a traumatic subarachnoid hemorrhage, and another one where they administered the medication intra-arterially, which is not very practical. So I immediately came to the conclusion somebody has to do a clinical trial, not to prove the safety, but to prove the efficacy. And I've been trying to get someone to fund the study. So if you know of anybody, please let me know. The company that makes the liquid form denied paying for the trial, but they said that they would give the liquid medication for free. Okay, so of the 3 proven methods, I'm just going to say a couple of words about neurofeedback because everybody here knows it better than I. But what I tell all patients is that they should always have a quantitative EEG with a Loretta analysis. It should always be neurofeedback of the Loretta type because it's more efficacious, it's faster, it's non-invasive. There's many different ways to do it. Adults and kids can be done. The methods of performing neurofeedback are evolving all the time. And we heard early this morning how we're going to be able to do neurofeedback on the cerebellum. It's going to open up a new dimension to that. And Thank you, Dr. Thatcher. It's cost-effective compared to medication because, as I said before, the drug is expensive, and is completely safe as long as performed by a competent therapist, which many of us have probably seen cases where people were hurt by neurofeedback, especially if they don't do the Z-score training. So now we're going to talk about hyperbaric oxygen a little bit. Most people know, everybody knows in the medical field that hyperbaric oxygen is very good for healing, except they do not recognize that it's appropriate for the brain. A couple of weeks ago, there was some approval for veterans coming back from the Middle East wars that they would be covered for PTSD and post-concussion with hyperbaric oxygen. It is performed in an airtight chamber. It could be one person, could be multiple people. It is 100% oxygen pushed in under pressure, anywhere from 1.2 to 2.0. It has 8 mechanisms of action that I could look up, although someone who attended another lecture of mine who runs a center says there's 32, but I haven't seen them, and has very little objections. So this is a very elegant study that I want to show you, which was done by an Israeli group. They took about 30 TBI patients, all post-concussion syndrome, and they did some baseline psychological test and SPECT scan, and then they gave them hyperbaric oxygen treatment. And this slide shows you the SPECT scan, both pre and post, and the top row shows you the SPECT scan in 3 positions. And the color scale, if you look to the left, is quite similar to the color scale that I use. Maybe not as many steps, but principle is the same. What you see on the top row is that the white arrows are pointing to areas of yellow and green, which are significant hypoperfusion. And then after treatment, those areas become completely normal. And the slide on the bottom is the delta of the increase of blood flow. And this is the same study where they did DTI study with MRI, and they showed, and the red arrows point to an increase of diameter and girth of these white matter tracts, these fasciculi. And you could just scan the slide from left to right, and you can see that it's pretty dramatic, except for maybe the one to the right, but nevertheless, it means that, you know, part of the brain is growing back, which is pretty miraculous, I think. Now, the next slide, as promised, is the first severe TBI, the gentleman sitting in a wheelchair both times, of his pre and post. So the left-hand slide shows the pre-SPECT scan. These are 3D slides. And the right shows the post as it's labeled. And the left-hand pre-treatment shows an arrow on the left, which is pointing to all these black holes and defects. There's blood flow missing on the left side compared to the right because the patient ended up with getting an infarct. That's dead tissue. It's a stroke, so no flow. And the right side has multiple defects. And if you gaze over to the right, the very first image, and you look at where the red arrow is, you see all white. And that indicates that there has been return of perfusion, normal now, which corresponded to the left-sided weakness, which resolved. And you can see the similar findings on the other slides. The next slide, I should say that the 3D that I just showed you was done, you know, what I call the old days. It was the first generation scanner, and as the technology has gotten better, the pictures get better so that what I'm showing you now is a lot more clearer because the technology has improved over the years. So this is the first mild TBI case who was hit in the head, went down for a minute unconscious. And the top row is pre-treatment, the middle row is post-treatment, and the bottom row is the difference known as the delta. And if you look on the top row all the way to the right, you see the bottom or ventral view of the brain. Basically, it's all blue. And if you gaze over to the scale on the right, you see that the blue is at the bottom, so you would obviously conclude that there's severe decrease of blood flow. Some of those colors are actually more than dark blue. Then when I write my report, I say greater than -4 deviations. So if you look at the 1, 2, 3, 4th frame on the first view, that's the left lateral view. You see that the left temporal lobe, especially the front of it, the anterior portion, is very, very blue, and it actually extends in a gradient posteriorly consistent with TBI. There's always a gradient from front to back and superficial to deep, and the anterior poles of the frontal and temporal lobes always smack up against the surface of the skull. And so the significant hypoperfusion there also at maximum deviation. And then if you look at the post-treatment, look at image number 4, you see that a lot of the area of the temporal lobe is now back to normal, and some of the area of the very tip of it is less blue, indicating less deviation. If you scan to the right, the last image of that middle row, and just look up and down comparing the pre and the post, you see that there's many areas that are not blue any longer, especially lateral parts of the bottom of the frontal lobes, and the area that is blue and dark blue has contracted down. The slide at the bottom is the difference between the two. So, what could we say, or what could I say to summarize and conclude? First, you have to identify the condition, and it's not always easy. Then, once you make the diagnosis, you provide the treatment. What I have called putting all these things together is the WAND protocol, and I think you have seen that it works. From the SPECT scan point of view, when I see deviations of about -2 deviations, I see a full clinical recovery. If it's more moderate, between -3 and -4, I see a moderate to almost full recovery. And when it's really severe, like the first 2 cases, there is some recovery, but it's not as complete because most of these patients have too much structural damage. In closing, I would like to apologize and thank you at the same time. And you might find it funny that I'm apologizing, but I have to apologize for the traditional neurology community. And that is because they don't know anything about QEEG, and that's a whole story explained in the book. And they're very narrow-minded, and that has hurt a lot of people. And my approach is integrative, and that's a huge difference I think you could see. I would like to thank the ongoing knowledge and technology that has improved and helped us all. And if there's anything that you could take home today as what I call a clinical pearl, is that yes, there is a treatment, and yes, it works. So this is the last slide. This is about my book, which was published on July 14th on Amazon, and it quickly became a bestseller. What could I say? Thank you very much.